Hello, I'm Elizabeth Deering. If we haven't met, I'm one of the GW Ultrasound faculty members. Welcome to this introduction to Abdominal Aorta Ultrasound. As an overview, for the next 20 minutes or so, I'm going to describe normal and sonographic normal anatomy as it relates to the aorta. I will then discuss the ultrasound protocol for evaluating the abdominal aorta. We'll apply this knowledge to ultrasound images of abnormal aortas. And finally, I'll explain the difficulties you may have with this exam and how best to overcome these difficulties. Now, if you are saying to yourself right now, why do I need to know about this? Here's why. Because ruptured AAAs have an extremely high mortality rate, and we know that the bigger the aneurysm, the more likely the rupture. But many patients do not even know that they have an aneurysm, and many patients don't present with the classic textbook symptoms. So what is the mortality for ruptured AAA? Around 80%. 80%! That means 8 out of 10 people with a ruptured AAA will either not make it to the hospital or not make it out of surgery. So every second counts when it comes to diagnosing a ruptured AAA. Luckily, ultrasound can help us rapidly diagnose an abdominal aortic aneurysm at the patient's bedside. But just how good is ultrasound? Well, remember this number, 99%. That's the sensitivity and specificity of ultrasound for diagnosing AAA based on a 2013 systematic review of ED-performed ultrasound. So here we have a deadly disease, a true emergency, and you can accurately diagnose this disease in minutes with bedside ultrasound, which can save a life. But before you go saving any lives, we need to go over the basics. So let's talk about the anatomy of the abdominal aorta. The abdominal aorta is a retroperitoneal structure that starts at the aortic hiatus at the diaphragm and courses anterior to the spine until it bifurcates into the common iliacs at around the level of the umbilicus. The abdominal aorta normally tapers as it courses distally and has a maximal external diameter of less than 3 centimeters. The aorta is usually less than 2 centimeters when infrarenal and less than 1.5 centimeters at the bifurcation. It is important to recognize that a normal aorta tapers in size, since a non-tapering aorta may actually represent an aneurysm as well. But in general and POCUS, an abnormal aorta evaluation would be anything measuring greater than 3 centimeters. There are 5 major branches of the abdominal aorta. First, the celiac artery. Second, the superior mesenteric artery. Third, the left and right renal arteries. Fourth, the inferior mesenteric artery. And lastly, the bifurcation into the iliac arteries. Now, while we would ideally see everything every time we do an ultrasound, we understand that this is not necessarily realistic. Bowel gas and obesity are real, and they can cause real sonographic problems, which we'll discuss later. But there are a couple of these landmarks that you must absolutely identify in order to have a complete study. These two are the SMA and the iliac arteries. Now that we've discussed regular anatomy, let's discuss sonographic anatomy. Let's start with the proximal aorta. You should notice the echo texture of the liver at the top of the screen. The liver will provide an acoustic window to the proximal aorta, as well as provide a landmark indicating we are near the subxiphoid. The first structure you should identify is the vertebral body. This appears as a hyperechoic curved line with posterior shadowing. Just anterior to the vertebral body are 2 large vessels, the aorta and the IVC. The aorta lies to the left side of the patient, and the IVC lies on the right side, which is closest to the probe marker. It is important to identify both of these structures and their relationship to the vertebral body to ensure that you are actually evaluating the aorta. Although sometimes difficult to identify in patients, the proximal aorta view also contains the celiac trunk, the first major branch of the abdominal aorta. The celiac artery is relatively short as it quickly branches into the hepatic and splenic arteries. Now, if you haven't already figured it out, we ultrasound people love our signs. And the celiac trunk branching into the hepatic artery and splenic artery gives us our beloved seagull sign. So, when you are searching for the proximal aorta, this seagull sign will let you know you are in the correct place. Now let's take a moment just to discuss the IVC versus the aorta. In these images, it seems pretty obvious which one is which. However, at times, especially new learners, may reverse their probe marker or may only see one of the two vessels. So keep these characteristics in mind to determine which one is which. The aorta should be pulsatile, both visually with B mode and with Doppler. It has a thick wall that is not compressible and does not change with respirations. The second branch of the aorta is the SMA, which branches approximately 1 to 2 centimeters below the celiac trunk. It courses between the pancreas and the third section of the duodenum, and its course parallels the aortas. In this image, we can once again identify our vertebral body, which should be your landmark in all the aorta views. We can then identify the aorta and the IVC. Above the aorta, you will note a vessel surrounded by hyperechoic tissue. That is the SMA. The SMA also gives us another sign. The appearance of the SMA with hyperechoic surrounding tissue is called the mantle clock. Remember, if you see the mantle clock, you are in the mid portion of the aorta. In addition to the transverse view, we can use a different plane to also visualize the relationship between the aorta and the SMA. Rotate your probe 90 degrees with the probe marker towards the patient's head. We can now look at the SMA in the longitudinal plane. This better shows how its course parallels that of the aorta. The right and left renal arteries also branch in the mid portion of the aorta. In this image, we will once again start by identifying our vertebral body. Anterior to the vertebral body, we can now identify the aorta and the IVC. We can also identify the SMA above the aorta. You will notice that at this level of the aorta, there are branches on either side. These are the right renal artery and the left renal artery. You will also note the left renal vein between the SMA and the aorta as it courses to the IVC. The renal arteries are an important branch point because the majority of aneurysms are found infrarenal. Finally, we get down to the distal aorta around the level of the umbilicus. We once again find our vertebral body and the aorta just anterior to it. Now, once we find the distal aorta, slide or fan distally to see the aorta split into the right and left iliac arteries. You can then fan proximally again to return to the distal aorta. So now that we know what we are looking for, let's discuss how to find it. AAA should be considered in any patient older than 50 with abdominal, back, or flank pain. Keep in mind that the pain from a AAA can also be referred to the scrotum, buttocks, thighs, shoulders, or chest, and many patients are misdiagnosed with renal colic, diverticulitis, or musculoskeletal pain. Obviously, if the patient has a pulsatile abdominal mass, you should evaluate their aorta. Lastly, any patient with unexplained hypotension or older patients with dizziness or syncope should have a bedside aortic ultrasound. Now for probe selection. Probes A and C in this diagram are both high-frequency probes. These probes have the best resolution, however they do not, in general, penetrate deep enough to view the abdominal aorta in adults. So, they are not our probes of choice. The phased array probe, which is labeled B in this diagram, can penetrate deeper than the linear probes due to its lower frequency. However, its small footprint, or the surface that contacts the patient, makes it more difficult to move bowel gas out of the way. The best probe for this exam is the curvilinear probe. This probe is a low-frequency probe, therefore it can image deep into the body. In addition, its large footprint allows constant pressure over a larger area to push the bowel gas out of the way. At GW, our only low-frequency probe is the phased array, so that's what we're going to be using. This shows the basic orientation for transverse and longitudinal views. Remember, the probe marker points to the patient's right for transverse and towards their head for longitudinal. Place the patient in the supine position and have them bend their knees to soften their rectus muscles, which will allow for an easier exam. There are a total of 5 images and clips that should be obtained for a complete exam. You should have measurements of the proximal, mid, and distal aorta in the transverse orientation. You should also obtain a longitudinal view of the proximal and distal aorta, and finally a clip of the distal aorta bifurcating into the iliac arteries. Some choose to start at the distal aorta since the majority of aneurysms are infrarenal. Additionally, the distal aorta is more superficial and therefore may be easier to find. Bottom line is that you can start either proximally or distally as long as you evaluate the entire abdominal aorta. We measure in the anterior-posterior diameter and from outer wall to outer wall. Measuring the outer walls helps to ensure that we do not underestimate the size of the aorta. Another cause of underestimation of size can be from the cylinder tangent effect. As demonstrated in this diagram, if you are off-center in the longitudinal axis, then you can underestimate the true diameter. It is for this reason that we measure the aorta in the transverse orientation. So just to review, we measure the outer wall to outer wall and the AP diameter of the proximal, mid, and distal aorta. We also want to identify the major branches in both the transverse and longitudinal view. Finally, don't forget to look at the bifurcation, as there are many aneurysms that extend to the iliacs. Here's a brief demonstration of the aorta exam. We will go over this again with hands-on scanning this afternoon. To begin, choose the low-frequency probe and apply lots of gel to the patient or the probe. Slide the probe to the subxiphoid area and identify your landmarks. You should be above the level of the SMA. Freeze the screen and measure the proximal aorta. Next, slide down past the branch point of the SMA into the mid-aorta. Once you are in the mid-aorta, you should freeze your screen and measure the AP diameter. Then move again down to the distal aorta just above the level of the umbilicus and the bifurcation of the iliacs. Freeze again and measure. Now you can fan distally to visualize the bifurcation of the aorta into the iliacs. Finally, rotate your probe to view the aorta in its long axis from proximal to distal. There are 2 main types of aneurysms. Saccular aneurysms only affect one wall of the aorta. A saccular aneurysm can arise from an aorta with a normal size lumen and may be missed if the aorta is visualized only in the median plane longitudinally or in intermittent areas transversely. Fusiform aneurysms affect all walls of the aorta and are the more common type of aneurysm. Here we have an abnormal aorta. We can see the vertebral body with the aorta sitting directly anterior to it. We are not clearly seeing the IVC in this image, so you should confirm that this is indeed the aorta as we discussed earlier. As you can see, this aorta's diameter is 3.46, which is abnormal. What do you think about this image? Well, lucky for you, the measurements are already there, so you know that this is an abdominal aortic aneurysm. What can you tell me about this image? Well, first, we're not clearly seeing our landmarks, so ideally we would have the vertebral body and the IVC in this image as well. And ideally, this measurement would be more AP, but either way, it is clearly abnormal at 6.86 centimeters. This image also shows the importance of measuring the outer walls. What you are seeing in this image is a mural thrombus. So if you were just measuring the lumen size, you may miss that this is a huge aneurysm with a thrombus. So remember, outer wall to outer wall. How about this one? This is a great AAA image. You can see your landmarks And your measurements are appropriate as well, measuring from outer wall to outer wall in the AP diameter. Once again, in this image, you can also see a mural thrombus. What do you think? Well, I hope this is a pretty obvious distal aneurysm. Remember that the aorta normally tapers distally and that most aneurysms are infrarenal, so the longitudinal view may help. Finally, what do you think about this one? If you diagnosed a posterior saccular aneurysm in the sagittal view, then you are correct. Notice how the aorta size on either side of the aneurysm appears normal, but this large aneurysm is hanging off one wall. I know what you're thinking. This looks pretty easy. I mean, those examples were pretty obvious. There's no way that you could not find the aorta and measure it appropriately, but it can be harder than it looks. So let's talk about some of the reasons why people may have difficulty seeing the aorta. Obesity makes ultrasound harder. Unfortunately, the extra fat can cause increased attenuation of the ultrasound waves and decrease the image quality. Some machines have settings that can help with penetration, but in the end, there is little we can do about body habitus. If a patient is in pain, they may not tolerate the ultrasound exam. If you are concerned about a ruptured AAA, then it is necessary to control their pain to facilitate the workup. Additionally, pushing on a person's abdomen that already has pain there can cause even more pain. So make sure you are adequately treating a patient's pain. The biggest problem people usually run into is bowel gas. Bowel gas can be really annoying. Remember that ultrasound does not like air, no matter where it is located. There are a few techniques to get it out of the way. First, you need to apply constant, steady pressure. This, in combination with peristalsis, will move the gas out of the way. But remember, constant, steady pressure, and it's usually a lot more than you think. Next, you can fan or slide or rock the probe in small movements, in addition to providing constant pressure to try to move the gas. Positioning the patient in a lateral decubitus position can also help move the bowel gas. Of course, not all patients are cooperative with this maneuver. And you can even use the liver as an acoustic window to visualize the aorta if all else fails. Make sure you are always optimizing your gain and depth for each image. For abdominal aorta ultrasound, I recommend starting with a lot of depth to make sure you find your vertebral body landmark. But once you do, adjust the depth to focus on what you are imaging. In this case, decrease the depth so you can see the anterior portion of the vertebral body and the vessels anterior to it. In the image on the left, I've highlighted all of the extra dead space. Don't forget to adjust depth to get rid of all of the dead space. The goal of abdominal aorta ultrasound is to rule out an aneurysm. We can do that by measuring the aorta. However, we cannot rule out a rupture with ultrasound. Let me repeat that. You cannot rule out a ruptured AAA with ultrasound. If there is clinical concern for a ruptured AAA and the patient has a AAA on POCUS, then it is a ruptured AAA until proven otherwise. Although the majority of bleeding is retroperitoneal, up to 30% can bleed intraperitoneal, so do a quick fast exam. And if it's positive, it can only help confirm your diagnosis and give you additional clinical confidence when calling the surgeons. But make it a quick, fast exam because you need to call the surgeons immediately if you have any clinical concern for a ruptured AAA. If the patient is stable, and you can consider a CT, but do not wait to call vascular surgery. So in summary, AAA rupture has a high mortality. Point of care ultrasound has a high sensitivity and specificity for detecting AAAs. A complete point of care ultrasound exam for the aorta includes 5 views, including 3 measurements of the proximal, mid, and distal aorta. These measurements should be from outer wall to outer wall in the AP diameter. An aorta measurement greater than 3 centimeters is an aneurysm. Lastly, in a patient with a clinical concern for a ruptured AAA and findings of a AAA on POCUS, it is a ruptured AAA until proven otherwise. Type and cross for blood and call surgery. All right, now's your time to shine. Get out there and save a life.